Can't guarantee this will be what it will be like in a week or even tomorrow, but I know what it's like today. So, oh, sorry. Sorry, I'm having technical difficulties. Okay.
We see you. You're great.
Okay, good. So currently, or typically, when you go into labor, you come in through the hospital and they would let you in and send you straight up to labor and delivery once they know you're beyond about 20 weeks pregnant. There's not usually any screening or making sure that everyone feels healthy or anything like that. I mean, obviously, if someone's really sick, they may want to discuss that with you, but you can also typically bring as many people as you want after you get admitted, and depending on your physician, often they're the person who may have a preference as to how many people you have present in the room, just because it can get kind of chaotic, right? And if there's an emergency, sometimes different physicians prefer to have it a little quieter and calmer, but there's variety there. Currently, with COVID, obviously, everyone's making dramatic changes in how all of that is going. Oh, sorry. Typically, then, whoever came with you can stay. They can come and go. They can get you food or bring stuff from home. They can go back out to your car to get stuff you forgot. So there's no regulation on that in your normal birthing process at the hospital. Currently, the process is a little different. So when you come to the hospital for labor or any kind of triaging right now, so any pregnancy-related complaint or something that you'd have to be evaluated for, they're going to screen you at the front door and ask about fever, chills, or any symptoms. And then, oh, sorry. And, whew, oh, sorry, I'm not used to getting these questions and seeing this while I'm doing it. My bad. So you come in, they screen you, ask you about fevers, cough, shortness of breath. And then as long as you and your support person say no, then they let you in, but you do have to wear a mask anytime you're in public areas in the hospital. Once you're admitted to a room, you and your partner, I mean, you're going to get your germs all over that. So it doesn't really matter if you're wearing a mask in the room, but you will see that all your providers and staff, as they come and go and are in the room, are wearing masks. As far as how many people that you're allowed to have or that come in with you, you can have one support person, whether that be your husband or partner or sister or whoever you want to bring with you. However, they cannot come and go. So they come into the hospital, they want to bring whatever clothes they want for the whole time they're there and any other items, because they're not even going to be allowed to go back down to the car to grab your bag. So you just want to make sure you're bringing everything in with you at your initial admission. If you do have a doula, they are allowed to come with you as well. So that would be 2 additional people. The doula does have to have a signed contract. So you can't like bring your sister and say she's your doula. You have to show that they've gone through training and that you have a contract with them to be your pregnancy support. And so then once they're in, the husband or partner support person is allowed to order food with you. So every meal, the partner can order a tray. We don't usually do that, but since we're not allowing food in and out of the hospital right now, they have accommodated that. As far as the doula, though, they do have to bring their own food. So they want to prepare for that. And kind of plan ahead, maybe grab a cooler. But, and then after delivery, there was a time when they were making the support person leave after the recovery period, but that actually has changed in the last couple days. So now whoever comes in with you as your support person and or doula can stay as long as you're there. And so as long as they don't leave, because then they can't come back in, but as long as they don't leave, they can stay with you in the room and be there for you throughout those first couple of days postpartum as well. And then we are encouraging patients to try to go home as quickly as possible in this time, just to limit their exposure inside the hospital. At Little Company of Mary, everything is on one floor, so all of the nursery, the postpartum, and we are trying to keep patients in their same delivery room if possible, just to limit movement and things like that. Sometimes it doesn't work out, but when it does, we just try to limit that so there's less exposure. We don't share the floor with any medical units, so there's not like COVID patients kind of in another wing, but it is possible that a pregnant female would need to be admitted with COVID, and we do have some isolation rooms with negative air pressure and things like that that we are prepared for in those cases. Then obviously there could be patients that are affected, but we don't know about it. And so we're trying to use all the precautions with wiping things down, wearing masks all the time, tons of hand washing, which should happen in the hospital anyway, but definitely doing those sort of things. And I think that's the main kind of differences. It is kind of weird as the provider too to always have a mask on when you're like pushing with your patient or rounding or things like that. But otherwise the interactions are still pretty standard. You still have a nurse who's there for you to support you as well. But yeah, the main thing is the visitors, I think.
So after birth, they're not allowed to have other people come in. So say they've got a 3-year-old.
Yep.
So that child isn't allowed to come and meet their sibling in the hospital.
Sure.
How many nights is typical right now for people to be staying? So typically my understanding and memory is vaginal births are 2 nights, 1 to 2 nights, cesareans are up to 4 nights. So tell me about that.
I think are usually up to 3 nights after C-section.
Okay.
But so currently, again, it's going to be patient to patient and how comfortable the patient is. So oftentimes our moms who have had children before are going home pretty quickly. So as long as the baby's been cleared, they do want to monitor the baby for 24 hours typically after delivery and make sure there's no signs of infection or other complications. But as long as everything there is going well, then moms are going home within 24 hours. So usually 1 night. But we do have some moms who are new moms and very anxious or different other complications who have wanted to stay. So they can stay up to 2 days after delivery. With C-section, yeah, typically it's like 2 to 3 days after, but you can stay up to 4. And then now, again, we're just trying to gauge it based on how the patient's doing and how they feel. We don't want to send people home rushed. We still want to give appropriate medical care and make sure that we're not sending you home unable to do your normal activities or at least unable to have the support to get those things done.
Yeah.
So, yeah, but I do think we're seeing more people. I had a patient go home last week, 1 day after her C-section. She was doing great, and you know, we stayed in contact. So if there are any complications, she'll know how to get a hold of me. But yeah, so I think it varies a little bit, but yeah, just encouraging people as soon as they feel comfortable that we can get them home in their comfortable environment. And that way to have all their family and everybody or kids, siblings be able to see their new sibling.
Yeah. So from my understanding, the risk of postpartum hemorrhage is highest in the first 48 hours. And if we're sending mamas home in 24 hours, is there any additional education on these are the symptoms you need to look for? Is there, I remember, I mean, granted, my oldest is 15 years old. So, and I had been in labor and pushed for a very long time. They gave me Pitocin after I delivered because I had a natural birth to help the uterus shrink down faster. I don't know if that is now still done.
Yeah.
That is done.
Still standard protocol to give Pitocin following delivery. Yeah.
With everybody across the board?
Mm-hmm.
Okay.
Yeah, unless it's refused, which is always patient choice. But if they don't mind, it does, I mean, statistically decreases any risk of excess blood loss and the need for blood transfusion. So we do just standard, it's hospital policy to give it.
Yeah. Okay. And then in cesareans, is the support partner and the doula, if they have 2 there, are they both allowed in the operating room?
So that's probably going to be anesthesia preference, honestly, because typically even outside of COVID, we only allow 1 person in the delivery room, in the C-section room, mostly because it's a tight space, and we want to make sure all the moving parts are able to get done what they need to get done. I think if there was a strong need or desire to have your doula with you in the C-section room, that could be discussed, but that would be case by case, just like even without COVID being in place.
Yeah, I had to fight for it. My mother-in-law had cut the cord on my first 2 babies, and these were her only grandkids she was going to be having. So she came with us into the OR with my 3rd one since she was breech. So I was happy to get that last person in there. Thank you. Good. So do we have any, I see Anne is asking, does the mom have to wear a mask while laboring?
No. So,
Good.
I mean, yeah, so you're encouraged to wear a mask at any and all times, but while laboring or pushing or once you're in your room, I mean, it's kind of assumed that germs are everywhere. So the mom and partner don't necessarily need to wear a mask in those moments.
And she's also asking a follow-up question. Should we not have any visitors at home post-delivery?
So I would say the recommendations post-delivery are going to be the same as for the general population, which would be no.
Yeah.
You know, I have a cousin who gave birth and they walked past the window and did introductions that way, which like tugs at your heartstrings. But I mean, at this point, just to help be safe for you and for baby and for your potential visitors, you were just in the hospital. If you were carrying something, it's possible to spread it to them. So I think right now it would just still be the same stay-at-home orders and social distancing, wearing masks all the time, things like that.
Yeah, great. All right, Katie,
Yep.
I am looking forward to hearing the home part as well.
Yep. You know, it's not too different, honestly. You know, we're taking precautions. We are, first of all, we're limiting our time spent in homes. You know, many of us do home visits where it's like non-essential visits. So if somebody at 6 weeks says, hey, I think I might be pregnant again, come over, and, you know, we're waiting until we really, need to see somebody. I'm a lactation consultant as well. So I'm pretty much only doing lactation consults for my midwife clients. I'm minimizing going all over the place to then, in order to isolate myself as best I can for my patients. And they're doing similar, you know, we're sort of on the same page with that. So when I do these home visits, I'm gloved and masked. It is hard, you know, I've learned to sort of see smiling eyes now. I'm sure everybody kind of feels the same. You kind of give that, like, you know, bigger smile so you can get that emotion across.
Little crinkles on the eye.
Yeah. You know, even after this euphoric, you know, home birth, you want to give a big hug, but, you know, everybody's doing what we're supposed to do. So the same, gloves and masks and washing hands, wiping down equipment, you know, so if I'm between home visits, I'm, you know, taking alcohol to all my blood pressure cuff and my tape measure and all of it, changing clothes after, you know, going from house to house, that sort of thing. And then doing the same when I have someone in labor. It's, you know, getting ready, especially if I've got two in labor, getting ready to go from one to the next and making that big midwife bag that we bring, you know, ready. And it's what we do anyway. But it's that extra measure with just all the little things and the moving of the gloves, and it's it does complicate things, but I think we're, you know, it's been a few weeks here now, it's kind of like gotten used to it. And then as far as, you know, there's a lot of conversation we have the same schedule as OBs. So we meet every 4 weeks up until 28 weeks. And then at 28 to 36 every 2 weeks, and after 36 weeks every week. And there has been some recommendations to sort of take out some of those non-essential visits. And what we do know is that those last few weeks of pregnancy, particularly 28 weeks on, when there's a higher chance of preeclampsia, gestational hypertension, you know, we've got more testing, we've got our second set of labs to do, our GBS. We want to see people. And so I'm continuing to keep that schedule pretty current and making sure people get seen during that time. And during those conversations, because our visits are typically about an hour, with our patients in the home. We're talking about, okay, well, how many visitors were you hoping to have at your birth? Well, grandma was going to come, and just I find that people are already in the mindset of isolating right now, so it's not a big surprise if we discuss, like, okay, well, let's not have, you can have your doula. I really see the doula as an essential person.
Yeah.
But home birth in general, I do like to keep things kind of, we don't need too many onlookers. The kettle doesn't boil when it's watched, right? So.
Any changes with using birthing tubs? And actually that I was going to ask Hope as well, if they're still allowing the tubs at Little Company to be used.
There was some talk about that a few weeks ago, and I think it was a little bit controversial. There's certainly, I don't want to speak for all midwives, because we really do, just like any provider, we have our varying degrees of being conservative. So I would say that there are some midwives that are not using the birthing tubs, just because with fecal transmission can be higher. But I think last I looked, that was kind of ruled out. So I'm not actually sure who's adhering to that. I haven't had too many people choosing the tub for whatever reason. As it gets hotter, they might be.
Maybe.
Or the opposite. It can be warm, so you want to walk around and stay cool. But right now I'm fine with it. I don't tend to like people to hang out in the tub anyway. It's more of a nice way, kind of an aquadural, to get through transition. And if it's their first time birthing, then oftentimes they actually do get out and get into various positions when pushing. So we don't always birth in there, but we might use it as a comfort measure.
Yeah. So while you brought up birthing, so as pelvic PTs, when we're looking at our literature or the international Urogyn literature, what we're seeing is these studies are not being done in the US, but they're being done in a lot of other European countries, that women who deliver in either side lying or in quadruped tend to have the least amount of perineal damage. So we do a biofeedback exam of patients when they are in those last few weeks before they deliver. And we work on, can you bear down and lengthen your pelvic floor gently? Obviously, we're not straining like we're in true labor, but getting that bear down, and which position can you best keep your pelvic floor relaxed? Because some people really want to squat, but they find a lot of people have trouble actually relaxing their pelvic floor in a squat, where the other positions might be better. So I would love to hear about the different types of positions that you're usually seeing your mamas deliver in, and then Hope, if you have any variations in the hospital, even with epidurals going into side lying. We also are working with those patients who have like disc injuries. And so they should not be in a typical lithotomy with their knees back position, because they're really going to injure their discs more, or they have a pubic symphysis disruption and they shouldn't have their legs that far apart either. They should be much closer so they're not stressing that joint. So these are the things we're looking at in our mamas before they give birth.
As you know, in the home birth setting, we don't have epidural, so there is that freedom of movement.
Yeah.
And as long as it's working, and first time pushing can be a while. And a lot of the time we're just waiting for that spontaneous, that Ferguson reflex, that we all know the sound.
Yeah.
We're waiting for that. We're not like, you're 10, you can push now. We're giving the body a chance to do what it's meant to do. So as long as it's working, I'm fine with it. And, as long as baby's good, mom's good, we can do squat for a little while. We can standing. I've seen a lot of standing. That's always a, get in there and catch kind of thing.
Yeah.
Hands and knees. And then, it really depends on the labor too. If someone's tired, sometimes they do want to be flat on their back, and they want to be on their side. So whatever works. and as long as mom and baby are doing well. We use warm compresses to protect the perineum.
Yeah.
And, sometimes there is some directed pushing if there's reason, if there's a good reason for it. If
Yeah.
mom's getting exhausted, if we're wanting to expedite the delivery for whatever reason, sometimes there's good reason to say, we would like to help you. But we always give her a chance to at least wait for that initiation.
Yeah.
You can really be in whatever position we hear that grunt. I really encourage intuitive movement. Sometimes I have to say to my patients, we're here for you, but if we weren't here right now, if we were alone in the woods having this baby, what position would you get in? And sometimes the focus is so much in their mind of, okay, these people are here to help me. They're going to deliver my baby, right? And just kind of switching the story a little bit and bringing that, what would you do intuitively if I wasn't here right now, can give them a little bit of a clue to, you know what? Yeah, I do want to get on hands and knees.
Yeah.
And I find those intuitive positions to be very effective.
Yeah.
Yeah.
I really did not think I would want to birth with my bum in the air, but it actually was an incredibly powerful position to deliver my second one. So, Hope, are you seeing other positions in the hospital? Do you have a lot of your mamas using epidurals, or do you have some trying to do drug-free births? What's the percentage you're seeing?
So I don't have exact numbers, but we definitely do see a variety. Obviously, we see way more epidurals than you would see in a home birth setting, 100% more. But I think as far as physicians and things go, and it's, again, I'm just one doctor out of many, and so my approach may be very different from other people's, but I think within our group and other doctors, I think we try to communicate with the patient about things they're comfortable with and what their desires are for their delivery, and if they have strong preferences about pushing or delivering in certain positions, then I hope that we're supportive of that. It's definitely, as a physician, you're there in case there's something more emergent, right? The majority of the time, the baby's gonna come and it's gonna go fine. So I think we're mentally prepared for complications. And so for us, the way we've learned to approach those is usually in the dorsal lithotomy position. So that's definitely gonna be our go-to, because as the doctor, that's where we're most comfortable. But again, I think we try to work with each of our patients in communicating what they really want and what they've pictured their birthing experience to be, and try to support them through that. So we do see different positions with epidurals. Mostly it's going to be side laying or tilted one way or to the other. We do use like the bar on the bed so that they can use that to either pull with a sheet or squat with and support themselves on that. And so there are a variety of options and things that the nurses are aware of and comfortable with too, in doing different positions during the laboring process, but then as well as with pushing.
Yeah. And in the hospital, you were talking about the limited number of, no new people coming after. So are they able to have lactation support come in?
So we have in-hospital lactation support. So I don't know if they're allowing, like if you had someone personal outside to come in, I doubt that they're allowing that, honestly. But we do have in-house lactation consultants that see most of our postpartum moms, unless they're pro and don't need any help. But they usually will round the day after delivery and help. And if mom needs more help, they'll come back or even come back the next day. And then they do follow up with them through outpatient settings as well.
Right. We have a question in the chat asking about, should I be worried about getting COVID while being in the hospital? So we have several pretty pregnant mamas on here with us today. So why don't you speak to that? And then I know I had emailed with you about that melatonin that I had heard about. So I'll just mention that briefly. But
no problem. So I think as far as being concerned about getting COVID, I think we all should be. And that's why we're all taking precautions and hopefully being safe in our day-to-day interactions and how much we're exposing ourselves to. Definitely, I can understand the increased anxiety about going into a place where other people are going because they may have that infection. at least as a physician, again, I'm biased, right? So our recommendations are still that I feel it's safer to come into the hospital and have those resources available. We're taking every precaution we can to maintain distance, normal cleanliness issues, but also everyone wearing masks, trying to minimize any chance of that transmission. At least at this point, I am not aware of anyone who's been infected through coming into the hospital. And so I just would say, if you're going to be nervous about that, I totally get it. I think a lot of women are looking at other options. Just make sure you're doing that safely with good support. But from our perspective, we still recommend the hospital attended delivery.
Yeah. So yesterday I was listening to a functional medicine webinar through a gal who was a pelvic PT and is now a functional medicine nutritionist. And she was looking at all the things you can do to support your immune system during this time. And one thing that she said that was very interesting to me was that people with higher levels of melatonin had higher resistance to viruses in general, but seemingly less episodes of COVID. So third trimester pregnancy is a time in our lives where we actually have elevated melatonin compared to the rest of our lives, but also infants and toddlers tend to have elevated melatonin. So she was saying we're just not seeing a lot of moms third trimester pregnant who are coming down with COVID. And maybe that's one of the things that are protective. So I was really happy to hear that, thinking about, it must be worrisome being third trimester and with all this craziness going on. I would love to hear both of you talk about postpartum follow-up and care. I had mentioned to both of you before we started that recently I was approached by one of the moms groups asking me to come in and speak to their new mamas because they had been reporting that their 6-week checkup was being canceled by their OBGYNs, that they didn't want any extra visits coming in. So I would love to hear what's going on out there in regards to that.
I wanted to mention the midwifery schedule. We stay for immediate postpartum. Obviously, it's not like, hey, congratulations, you clean that up and now we're leaving, right? So there's a lot to do. We do the newborn exam. We're monitoring vitals of both mom and baby. We're doing vitamin K shot if they choose, prophylactic eye ointment for the baby, should they choose. We're staying, usually 4 hours, 3 to 4 hours, and then longer, obviously, if there's a need to. And then we come back at the 24-hour mark, if not before, so we leave a whole bunch of instructions. And so we've got mom up to the bathroom, we've checked her bottom, they're all tucked in for the night, everybody's good. And then we come back about the 24-hour mark, many of us do the newborn screening. So, and that's the thing that's keeping a lot of people in the hospital, because they might be good candidates for leaving beforehand, but there's this newborn screening is done after 24 hours. So we're able to do that in the home, which is nice and convenient. We don't have to send people out at that point. And then also the CCHD screening for congenital heart defects, which is done with a pulse oximeter. And then again, we're coming back and doing mom's vitals. We're doing a whole postpartum exam at the 24-hour mark. I like to come back about day 3 because that's when most people get engorged. That's when the breastfeeding concerns arise. Is my baby jaundiced? Then I can refer out to a pediatrician earlier if needed. And then come back around the 2-3 week mark again, and then it's 6 weeks. So we're doing a lot of postpartum follow-up in the home birth setting.
Great.
And for us, I think we are changing our approach slightly. We are not canceling visits, but we're doing more of those via video or even telephone. as long as they had an uncomplicated delivery. Obviously, if they had a severe laceration or things like that, we're bringing them back in sooner to evaluate that. But we are doing, there's the Edinburgh postpartum depression scoring system and things like that that we continue to follow in that postpartum period. And we can send that to our patients through our electronic system. And so they're able to fill that out and we can talk with them if there are concerns. I do counsel my patients postpartum just to talk with them about potential postpartum depression and signs and symptoms and reassure them that that's normal, and please reach out to me if these things start coming up and you feel kind of all alone, and we can definitely get those patients in sooner for video or even an office visit if needed. But right now we are trying to limit that in and out of the office to protect patients as well as our staff. So that's kind of what we're doing postpartum.
Yeah. So I will put one little vote in for telehealth physical therapy. Send them to us for their 6-week check, and we can do a lot of those screenings for you as well.
Yeah.
Which would be great. All right, I have a question in the chat. What is Little Company of Mary's protocol on gentle C-sections? Can you request a clear drape so you can watch the baby being born? I know Torrance Memorial, I think, with Dr. LaPellas made some big changes a couple of years ago with the golden hour and the babies being able to go skin to skin after C-section, and the clear draping. So I'm assuming Little Company has followed along with that.
I think LaPellas actually did it at Little Company, but his definition of gentle C-section is different. Anyway, so it sort of depends on who you talk to about what that term means. So
Yeah.
just say, if that's something you're interested, just know which parts of it are important to you so that you can communicate those things. Because just saying, oh, I want a gentle C-section is going to mean a different thing to different people. As far as, I don't believe actually that Little Company of Mary has a clear drape. Typically, if patients want to watch or see the baby being born, we actually will drop the drape down. And so that it's still more difficult, honestly. There's still going to be extra tissue there, but we can help lift your head up and help you see baby being born. And so that's just something you need to specify because we don't automatically do that. We are trying to do a lot more mom and baby contact following C-section. So as long as mom is feeling up to it and alert, we do try to have baby come over from the warmer after the initial assessment and be placed right on the chest, and even sometimes start breastfeeding back in the OR. And so I think we're trying to do that as long as possible. And then when we move the mom out to her like post-operative area or the room, typically the baby's going with the partner, at least briefly through that. And if the mom's not feeling up to it, we're often doing skin to skin with the partner or the support individual back in the delivery or the preoperative room, and they're going to be postpartum room as well. And so those are kind of the things we're looking at. I think, yeah, again, with general C-section, I think a lot of docs, we do things the way we just routinely do them. And so if there are things that are important to our patients, it's just important to discuss that with someone so that you know, and we can prepare for that ahead of time, because we're open to it and we want it to be a positive experience for you. But if it's last minute, then sometimes it's difficult to coordinate that with everyone.
Yeah. And back to the postpartum for just a minute. So you're doing either telephone or virtual or in person around 6 weeks. And then is it typical that they won't come back for a year for their well woman exam?
Yeah, if they're doing well, it would depend. We don't routinely set up follow-up visits from that. So we do talk about birth control. So sometimes patients get scheduled, but there is no routine follow-up after that 6 weeks for that postpartum kind of check-ins and things like that.
Yeah. Okay. All right. Awesome. I think that was all my questions. Katie, what happens if it's a breech baby?
If it's a breech, so midwives here in California, we don't do breech at home. So we're palpating for position at every visit. I like to see babies head down. 34 weeks is nice.
Yeah.
Hopeful. And if not, then I can refer to, so there's a bunch of things we can try, position changes and spinning babies and all that. But at some point, if it's persistent, I usually refer out to an OB that has a very good track record at doing versions, should the parent choose it. not everybody wants to.
Yeah.
Another option is a provider who does breech in the hospital. So I just had an incredible experience of seeing a twin breech birth at Long Beach Memorial with Dr. Chan. And it was non-induced, breech, two boys.
Wow.
And I've doulaed for years, so I was her doula, and I was able to. This was before, just as COVID was really starting to change the policies, but I was able to be in the operating room. It was in the OR just in case.
Yeah.
So there's a handful of OBs providing breech birth. It depends on the there's different kinds of breech, right? So there's some that might not be good candidates for a vaginal birth. And then it's up to the parent too, and they might have certain things that make them at an increased risk if they've had a previous C-section. There's a few different things that would make them more at risk for a vaginal breech birth. How the baby's positioned, of course, too. So there's options, and that's what I do is, we specialize in normal physiological birth with low risk women. And if things come up, if I've got someone that's looks like they are getting cholestasis, we do the labs. If they are, we refer them out, and they then move out of midwifery care, or we collaborate until we've kind of come to a decision of, you be best birthing here, or this is resolved. Your placenta isn't previa anymore. You're great. You're a good candidate for home birth. So I'm lucky to have a lot of really good relationships with OBs. It's wonderful because we each have our specialty. So.
Yeah, excellent.
Yeah.
Hope, are they still allowing versions to be done like a week before delivery?
Yep. Yeah. So we still do versions typically, 37 to 38 weeks. We check position around 36 weeks. And then if there is a breech presentation, we then counsel the patient on options. So version or primary section. I will say, I think Dr. Chan is something of he's a rare bird, but he is, he'll do a breech delivery and he'll work with us with them too. So he's pretty amazing. But so for those, we do that. I think the majority of docs will do second, if a twin pregnancy, doing a breech delivery on the second baby, as long as the size is appropriate. But that's typically the most common things are version or C-section.
And can you explain to people what a version is and kind of how that is done?
Yeah, so a version, it's called external cephalic version, which means we bring you into the hospital and we're trying to externally rotate the baby so that it flips, somehow somersaults from being butt down to hopefully head down. And so you can imagine it's a very hands-on procedure. But typically you come into the hospital, they're gonna start an IV and kind of sort of get you admitted, because we do wanna be prepared, because with a version, there are some very rare but potentially serious complications. And so we counsel about those before even trying it. But then when we do it, we usually use gel or mineral oil or something like that all over the belly to help with maneuvering. And then we have an ultrasound in the room as well in order to follow baby's heart rate, make sure baby's tolerating kind of the pressure and maneuvers. And then typically you'll have two physicians performing the procedure. And so typically it's the doctor you've been seeing and one of their partners. But at some point we put our hands on and try to elevate baby up out of the pelvis, and then kind of feeling with baby which way they feel more comfortable turning, or it seems more promising, kind of trying to encourage that, and then periodically checking that heartbeat again throughout the procedure. And it depends mom to mom too, I think, on how well you tolerate that, because it can be very uncomfortable. And some physicians will talk about, like, we can offer epidurals or different things like that if someone is like dead set on it and wants to do it. And I think those are options, but of course that's more invasive also. So it's always a discussion in how we approach that. But then if the version's successful, we monitor baby usually afterwards for at least half an hour to make sure the heart tones are looking good, that baby tolerated that. And then we would bring you back, or when you go into labor, recheck position as well.
Great. I had one unsuccessful, unfortunately, with baby number 3, but I remember it clearly. I think I actually said to the OB, could you leave my bladder where it belongs? Like, that did not need to go with the baby at that point. So when we're talking about positioning, and we have a mama who's to pushing phase, and you realize that baby is sunny side up, are there other positioning things that you do at that point to try to get baby to flip occiput anterior, so the delivery is a little bit easier, at least for their pelvic floor?
I think Katie probably does a lot more of this hands-on than I do. I know we will try rotations and things like that, rotating patient onto the side to see if that will help with gravity, help baby rotate around. Sometimes with checks or with pushing too, as the physician, we can try to kind of give the baby's head a little nudge in that direction. You don't want to push up too much because you can get a cord prolapse, which is obviously a big deal. But we can try to kind of assist that maneuvering with pushing. Most babies will kind of flip around while they're going through that process. But if you get those stubborn ones, then I think, yeah, it's most of that stuff usually happens prior to me getting there. But we do some of those things at the end as well.
Yeah. I had a labor and delivery nurse help me with my first one who was sunny side up. She ended up being a brow delivery, but at least her occiput was in the right place. Katie, what about you with playing with positioning?
You know, there's posterior and there's persistent posterior. So, you know, a lot of people will get worked up in pregnancy because they're like, oh, you know, we say, oh, we just feel lots of bumps in the front, you know, your baby's posterior, and they are concerned about that. But a lot of the times the babies will move in labor. And so what you're talking about, I think, is that persistent posterior. They're coming down and not exactly where you want them to be. And usually, especially if it's the first push, it can prolong the labor and it can exhaust the mom. So, you know, ideally we want to get baby in that optimal position. And there's a wonderful midwife who developed Spinning Babies. The website, I believe, is spinningbabies.com. And so many of us are trained in spinning babies techniques. And she has just so much literature and position ideas. And, you know, we try them all. Sometimes we have someone crawling on the floor, you know, without the epidural. Obviously, there's a little bit of mobility. But I have seen in the hospital setting incredible nurses, especially, I absolutely do love Little Company of Mary. You know, you can get pretty creative with pillows and positions and getting people to, if they're willing, hands and knees can be a really nice position, home or hospital, to encourage babies back to come forward a little bit more, and time. And oftentimes they will rotate, and moms can feel it, and all of a sudden they go, oh, okay, all right, now, okay, that feels better. Not being medicated, I think, does, you know, it does lend an advantage to rotating mom, getting mom in the best position so that baby can also turn. And some doulas will have special tricks like rebozo. Some midwives will use the rebozo, which is an incredible Mexican midwife. It's a cultural, it's a practice, it's an art. And some people are very, very well trained in this art. So there's a lot of wisdom, you know, that can be found sort of outside of the box. But sometimes people just need time. They just need a little more time. And then sometimes you can go in there and give things a little bit of a nudge. And sometimes they're born posterior. You know, we do our best and then we send them to you. Right?
We'll take good care of them, I promise. So what happens if there's a severe tear at home? I mean, I know the likelihood is much smaller, but then do they transfer to the hospital for suturing? What does that look like?
We are trained in first and second degree tears, some third degree tears, but we have the lidocaine and we have the suturing material, and we are trained to repair. So we do it at home.
Do you guys do fourth degree repairs at home?
No.
Okay. So if it was, and again, more rare in the home birth setting.
Then we transfer. Yeah.
Yeah, I've heard some hospitals take fourth degrees actually to the OR and have a colorectal surgeon work on them. Hope, is that ever done at Little Company, or is it typically the OBGYN who's doing that?
It's typically going to be the OBGYN. I think the recommendation to go back to the OR is a umbrella recommendation for that, for your visibility. Now sometimes depending on patient and the room and if they have an epidural or not, sometimes you can get great visibility in the delivery room and then you don't necessarily need to do that. But I do think, especially with those more complex tears, it's extremely important to make sure you're bringing the levels and layers of tissue back together appropriately. And so making sure that you can optimally identify that and do an appropriate repair is extremely important.
I don't know how you guys do it, putting it all together. I got to see a good friend of mine birth, and I swear her tear was this long. I'm like, where is her anal sphincter? I'm down at the end of the bed and I'm looking around, and it was enormous. And it was Dr. Fisher delivering. And she's like, oh, that's just second degree. I'm like, how could that just be second degree? Like, that tissue just expands so beautifully to let babies out. But then the idea of making that match, I am glad that is your job and not mine. I will rehab them after all day long. But okay, we have a couple other questions in the chat that I want to bring up. So we have a mama.
Just one thing quick, just because you talked about persistent posterior rotating, and I just wanted to mention, because I get a lot of patients at 28 weeks who are like, my baby was breech on the ultrasound. I'm really concerned about this and kind of anxious about that. And I know Katie mentioned it as well, but we often will see breech babies until 34 or even 36, or after 34 weeks. And really the position matters not at all up until that like 36 weeks or until you're closer to term. And so I just encourage parents not to get too far ahead of themselves at like those early ultrasounds, depending on baby's position. Sorry.
No, that's great. It's when baby's an abdominal organ and not a pelvic organ. It's that uterus is in very different places at that point. All right. So we have a mom who's going to be delivering soon, and she's asking if we have a yoga ball, her bag, pillow, dad's bag, how do we bring that up in one trip if they're not letting you leave to re-enter, especially if she's in extreme labor and can't carry a lot?
Right. Yeah. So typically they'll bring like either a wheelchair or a gurney. So you can, or not a gurney, but like a little cart to bring your stuff up with.
Okay.
And I think if you don't know that you're being admitted, they have let dad go down. But if you can get everything up there, it's just going to be simpler for you guys once you're there. But I think in extenuating circumstances, they'll let you go get your stuff, but it's just not to make a habit of having to go back and forth.
Yeah. We have another question. I think you actually answered this earlier, but are all OBs still seeing patients every 2 weeks after 28 weeks? And are these visits still typically in person?
Yeah, so no is the short answer. I know Katie mentioned that she's still doing the standard OBGYN spacing. And I think everyone has their own approach to that. We have chosen to follow, there's the SMFM, or the Maternal Fetal Medicine Organization, came out with recommendations, as well as Kaiser and UCLA, looking at kind of the visits where it's the most important to check in, where things need to happen for the pregnancy, as well as kind of alternating visits. So if they're seeing a high risk physician for any complications in pregnancy, we used to be like, okay, you'll see them and then come right up and see us. And now we're like, okay, you saw them, they said baby looks great, you don't necessarily need to also come see us. So we are spacing those out a little bit more. So we're still doing every 4 weeks up to 28, but then we are doing another 4 week to 32 and 36. But then after 36, again, the farther along you get, the higher the risk of complications. And so we are seeing patients weekly still after that 36-week visit. And again, it's very patient to patient. So if you're more complicated or have medical comorbidities or things that we also are concerned about with the baby or the pregnancy, then we're adjusting that as we need to. And we are doing phone check-in visits and a lot of communication through like our electronic medical record system right now as well, just with things that come up in between.
Great. We have a successful, Anne said the last time her L&D nurse at Little Company got her sunny side baby up to turn with side lying and top leg over, which I love. One of the things we talked to our mamas about the last couple weeks before delivering is to spend a lot of time in quadruped. Like, don't just lay on the couch with your feet up all the time, because baby wants to then be sunny side up, and we really want to encourage them. So if they can sit on a birth ball and lean forward towards their couch, or read in like a child's pose position, to just keep encouraging baby, this is where you want to be, this is where you want to be before birth. So those are things we're talking about.
Is just on all fours, right? I think someone asked a question just so they know.
Yes, so quadruped is all fours. Yeah, it's our fancy word. Dina's asking, does an already or recently diagnosed COVID-19 mom need to wear a mask during L&D?
Yeah, so if I think labor and delivery is, again, this is an area I think that's evolving day to day still in understanding infectious potential. But if someone was recently COVID-19 or a new diagnosis and goes into labor, we do recommend that they wear an N95 mask, which is a mask that's going to hopefully prevent those viral particles from spreading.
Great. So how can we define high risk or inappropriate for home birth? And how do people properly research and prepare for those who prepped for a hospital birth and now are considering switching to home? So maybe you handle the first one. What are the ones that you think should definitely be the medical route? I would say the preeclampsias, obviously, and the placenta previas.
Right. Yeah, there are some obvious just straight contraindications, which I think Katie kind of mentioned before. We don't recommend anyone who's had a prior C-section try to deliver at home, or a breech baby, or vasoprevia, or other like placental complications. And I think too, this is where it becomes extremely important to have a midwife or whoever you're talking with about your home birth who's certified and well educated and practicing appropriately, because I think these are things that if you see your midwife, they're going to do a consult with you, and if they feel like you're inappropriate to deliver at home, or if something comes up through the pregnancy, the goal is that we can have a team approach, right? Where it's not necessarily like, no, I still got to keep her, we're going to do a home birth, because no one wants to put that risk on their patient or the baby. And so I think that's where making sure you're choosing your person is extremely important, because they're going to refer you over. But yeah, I think medical complications in pregnancy, just or diabetics, often if they were pre-existing, I think that can be an issue, but I know everyone's going to practice a little differently. And so I think there are, my guess is, and again, Katie, you can speak more on that, but like guidelines for things that are or are not appropriate from the midwifery standpoint as well. Yeah.
So when you said somebody with a prior cesarean, is that because you're concerned about placenta accretia?
I think it's that, as well as concern for uterine rupture, right? So it's not a huge number, but 1 in 130 women who have had a prior C-section are going to go through uterine rupture, at least statistically. And so again, it's probably not going to be you, but if it is you, it's a huge deal, and you can see fetal death from that. And so, I mean, that's why as an OB, at least, I would never recommend home birthing with a prior C-section.
So in that number of women who have the uterine problems post, are they more often in women who are delivering within 18 months of that first birth, of that cesarean birth?
So that, no. So the statistics looking at the 1 in 130 are going to be women outside of the 18 months.
Okay.
So before 18 months, I mean, straight across the board, I wouldn't recommend even a trial of labor. And again, I know every woman gets to make their own educated choice, but at least from the medical perspective, that risk is substantially higher. And so the 1 in 130 is from one prior It dramatically goes up if you've had more than one. So if you've had two, it's like 1 in 33. So, and it also, all those factors are going to be dependent on how you are closed and how you heal, but there's no way to factor in those personal perspectives or personal attributes. And so those are just black and white numbers, but medically that would be my recommendation.
Yeah. Katie, you want to speak to that?
Yeah, you know, there's midwives that take VBAC and there's midwives that don't take VBAC. I think the ones that do take VBAC are going to be very, very, you know, it's very important to look at the medical records and to look at the spacing and look at how the what the reason for the C-section. You know, you're really going to be looking at that person's chart critically. Most require an ultrasound and they want to see where the placenta is. They want to follow up if there's concerns as to what the placenta is doing as the pregnancy progresses. So we don't, across the board, we don't have any rule that says we can't do VBAC. Some do and some don't. We support birth between 37 and 42 weeks. Prior to 37, we can't birth at home. And after 42 weeks, you transfer in. You know, but the role of the midwife isn't always the birth. It is, you're getting prenatal care. You are getting that person who's referring you, you know, we're taking care of the whole person. So I have seen some incredible births where we've supported them all through pregnancy. And then it's time to, you know, say, you know what, you're risking out of home birth care and I'm with you and I'm with you. You birth somewhere else because of this situation. And then I'm with you in postpartum. So it's not that you are just, it's not just about the birth. And then, you know, yes, there's a whole list. I mean, there's a whole list. It's easily found online, but there's conditions, obvious conditions where we would not take people, right?
Yeah.
So yeah, you have to be low risk. And that doesn't mean that you have to be under 35. And it doesn't mean that it's not a VBAC, but we're very discerning when it comes to who we take on.
Yeah.
Yeah.
Okay, so we have a question. If you're scheduled for a C-section, but go into labor before the C-section date, would you recommend trying to do a VBAC or get a C-section? So we know this person personally, all of us. She is one of our dear staff, actually, who is due relatively soon. So I think I know the answer to that, but Hope, do you want to?
I mean, similar to what Katie says, when you're looking at the patient, if they're a good candidate for home birth VBAC, right? Like if you had a C-section in the first place because baby's heart tones dropped or it had nothing to do with difficulties with pushing or things like that, then I think you have a higher rate of success. So any VBAC success rates, and again, grossly on average, 70%, right? So that's almost 3 out of 4 patients who are going to be able to have a vaginal birth after a previous C-section. And that's great. If we can get you to that, I fully support that. And especially if you go into labor on your own, I think there's a great opportunity there to see how your body progresses. I will say, I think most obstetricians, we're just going to be a little more cautious with that. So if we're seeing concerns with the baby's heart tones or we're seeing issues with labor pattern or things like that, then that's something we're going to communicate with you as we go. But yeah, I fully support having a vaginal birth if you go into labor. And even if you don't go into labor, it's definitely an option to discuss.
Taylor, I hope you are not telling us you're going into labor early. We are not ready for that quite yet. We just have her coming back to work next week. All right, other questions? I'm trying to see if there's anything I missed in the chat. Are there any changes with fetal monitoring? For example, requiring continuous versus intermittent?
Changes.
So what I would say, what is the normal in the hospital? From my understanding, typically they like to have continuous, but mamas can ask for intermittent instead.
Yeah. So especially if you're doing a natural birth and not having augmentation or other pain medications or things like that involved in your labor course, intermittent is definitely an option, and there's a lot of good support for that. However, and I know I see a lot more patients who are going to be augmented with medications or have pain meds going on, and if in those situations we do continuous, I think, again, this is a situation where communication and kind of educating yourself on what's important to you as you come in, or speaking with your OB before, is really helpful also, because nurses are routinely, they're just going to do continuous. I think it's what we're used to. We like having something to look at, even though statistically it's not all that helpful. But we enjoy that, and we can document on it, and that's what we're kind of trained to do. And so they keep you on continuous. But I do think asking for intermittent for low risk and uncomplicated labors is a great option.
Yeah.
But there's no changes currently based on COVID or anything like that with how we do that.
Yeah. Katie, how do you monitor heart rate or baby's health at home?
Yeah, so we use a Doppler in active labor. We're monitoring about every 30 minutes, unless there's a reason to monitor more. So we'll monitor maybe if she changes the birth settings, if she gets into the pool, or after there's a spontaneous rupture of membranes. I want to listen, I want to hear. And we're listening before, during, and after a contraction, so that we can sort of see how baby is responding to the whole surge. And then during pushing, we're listening more frequently, about every other contraction. And again, more frequently if there's a concern. And then, of course, if that isn't resolved, we're obviously transferring. But so intermittent, generally intermittent. You know, we don't have the machine that hooks you up continuously. But there's good evidence for what we do at home too. So yeah.
Excellent. All right, so are there any points that either of you two think we didn't ask about, didn't bring up, that you think would be important for mamas to hear about? Any of my PTs on who have any burning questions?
I'd like to mention that, you know, I think that women need to birth where they feel safe. And so I've had a flurry of inquiries from people that are like, well, I'm scared to go into the hospital, so I've got to have a home birth now. But there's an epidural available, right? I'm like, you know, it works best if this is something that you had always sort of dreamed up. And you know, not that people can't completely change their perspective or achieve what they want. But you know, I don't want people moving out of the hospital setting and into home birth out of fear, because then they're going to get what they don't want, which is our most common reason for transfer is wanting an epidural. It's not an emergency. I spent the whole first night of my prodromal early labor, you know, on my phone timing these contractions because I was anxious and should I call my midwife? And then now they're too tired and now they need to go in and have an epidural. So, and then that's what they didn't want, right? Because the hospital is just so scary. So I just want to encourage people to look at the reasons for wanting a home birth. And I have supported some incredible births in the hospital. I have friends that are OBs. Little Company of Mary is my favorite. I won't say anything about some of the other hospitals, but you know, I have friends that are nurses and OBs, and you know, I do think doula support for the first pregnancy is important, and to just be open and honest about what feels right for you. I think that's really important. So
excellent. So if people have more questions for both of you, tell them where they can find you.
I'm gonna have to look up my email address. I don't even know. I think it's gonna be H Vermeer. So my first initial H, and then Vermeer is VERMAIRE. It's gonna be at mednet.ucla.edu. So yeah, shoot messages through there.
Do you work with Dr. Lukeman and Sparks?
Yeah. So Dr. Sparks says amazing things about you, Katie.
I love her. I
If
love
you
her.
want a home birth, then go to Katie.
If you want a hospital birth, yes. Yeah.
Yes, so I'm in that practice.
Neat.
Excellent. And then Katie, tell them your contact information as well.
I am mamanurtured.com. So it's NURTURED.com. And I also have a Yelp page, which with a lot of info on there too, and an Instagram.
Okay.
So.
Okay, I am putting it in the chat.
I'm Mama Nurture Birth on Instagram. Yeah.
Okay, awesome. Well, we thank you both so much for coming on with us. That was really great to be able to talk about, and obviously we need both ends of the spectrum for all our mamas to be able to have the births that they want and to feel supported, and as you said, to feel very safe in what they want to do, because it is a big day. We see that the 80-year-old patients we see can practically tell us minute by minute what happened during their labor and delivery, because it's just a day that's kind of burned into our brains, which is a great thing. But you want it to be one where you are happy about where you are and feeling supported. So I thank both of you for helping hopefully clear up some fears about getting sick in the hospital and those sorts of things. And we appreciate you spending your evening with us.
Oh,
So we did, go ahead.
Because you mentioned the melatonin, and so I had done a little research because I hadn't heard about that, but I did see that there are some hospitals at least trying it right now on high doses. I know evidence-wise, there's nothing scientific at least yet, but also the question for me was, if it's protective in pregnancy, then why isn't it protective from things like the flu or things like that, where pregnant women are still more susceptible? So anyway, it'll be interesting to see how that plays out.
Yeah, and I can send you that webinar. I have it if you want to see it.
Sorry, my dog wants to say hi.
Yeah. That's great. All right, I don't think I have any other questions. If anybody wants to ask any burning pelvic health questions, this fourth week our plan was to do a Q&A over the pregnancy and postpartum and pediatric topics that we had last week. Or if everybody's feeling really good about that, I'm not seeing anything pop up, but I'm going to give it another minute or two. So if you have any of those questions from the last 3 weeks, shoot them in there. I think we were trying to answer the questions as they came up over the last few weeks as well. All right, I am not seeing anything. So thank you very much. We really appreciate you taking your time to be with us.
Thanks so much for having me. Nice to meet everyone.
Yes, yes.
Thank you so much.
All right. Thank you, everybody. I'm going to take us off the air. All right, good.